Oh, good evening, everybody, and thank you for that welcome introduction. Thanks for everybody taking time out of your busy schedules. Like Susan said, Kirsty unfortunately couldn't be here tonight, and you don't want me to talk with a British accent for the next 45 minutes, so we're going to not do that. Okay, that is the last time I do that. That is just for Kirsty for later on. We got to try to have fun with stuff. Um, we're going to talk about Gulp tonight. Um, Especially I think it's a really appropriate topic this time of year as we get into these heat blooms. And what do we think about is the classic Labrador who we can hear breathing a mile away, right? With the heat stroke, heat exhaustion, these older dogs, especially the black labs, right? This just becomes a turbulent area and a dangerous one, right? Like most of our world in rehab is not critical care, right? But these are the dogs who potentially could have life-threatening events in this type of weather. So let's jump into it a bit, if my slides will behave. Of course, my thanks to Zoomatica for putting everything together tonight. I am strictly pinch hitting. These are all Kirsty slides, minus one or two that I added in. The benefit of working with someone as fantastic as Kirsty is, it's kind of like having two, you know, it's having a clone of yourself, except she's smarter and British. So we'll be able to pinch hit and talk a little bit about a disease that we all see, whether it's in Houston or Latham, New York, or Philly, or wherever around the globe it's hot and ugly this time of year. Learning objectives for tonight, we'll go through fundamentals. We'll talk about Gulp. We're going to do some anatomy review. It is always anatomy that comes down to being understanding. You can get a good importance out of this. And we're going into treatment and the role of targeted pulsed electromagnetic field therapy with this. And then we'll have some time for Q&A. As you can see, we're going to have a lot of Labradors and Retrievers on this, but they're not the only breeds for it. But what is GOLPP? Okay. We like to have acronyms in vet med. This is a newer one, right? Back in the day, 15, 20 years ago, we just called this LARPAR because it was laryngeal paralysis. Now we really understand that it's a syndrome of geriatric onset laryngeal paralysis and polyneuropathy. So that's where we get those 5 little letters from. But what is it, right? Unfortunately, it's becoming a common condition affecting older, often larger breed dogs, where the laryngeal innervation generates over. The affected cases often have that loud breathing. It sounds like they're snoring, but they're trying to just walk down the hallway or walk in from your parking lot into your clinic. They're therefore going to have exercise intolerance. They're going to have frequent throat clearing or dyspnea episodes or collapse. And as you're watching through the slides, remember Kirsty is British, so there are some British spellings of words in here, but we're all speaking the same language. And if anybody's on tonight from Michigan State, okay, MSU is the focal center of research for this disease currently. In fact, there's been some latest research out of MSU that not only can these dogs unfortunately have laryngeal issues, they may also have impaired esophageal function as well. But when we're looking at this, remember, we're talking about a degenerative condition of the peripheral nervous system. And the actual histological change is a chronic axonal degeneration. And this is why science gets better over time, right? We had our LARPAR dogs 15, 20 years ago. They also seem to be some of these older labs that had impaired sciatic nerve function, but they didn't have lumbosacral disease. Right? They didn't have an L4S3 spinal cord issue. They had a peripheral neuropathy. And as we started to take those two independent diseases, what research showed was that under the microscope, histologically, the same exact changes were happening to both the sciatic nerve and the recurrent laryngeal nerve. So that's why we globbed this together into GOLPP, right? The age range for this is about 8 to 13 years, Labradors, Labradors, Labradors. but also Newfies and German Shepherds. There's the top three. The key change for all my technicians and assistants on this, when you are all taking history, you can figure this out, okay? You hear the dog walk in, you know the signalman fits, and if you're not sure, ask the pet parents, hey, has your dog gone through a bark change? Do they kind of sound like a kid going through puberty, right, where a guy's voice changes? And that is the red alert, right? That's where we have to start thinking that they're not lagging behind because they're painful. They're lagging behind because they're neurologic, because they can't breathe. And if you can't breathe and you can't get oxygen, you can't go anywhere. So that bark change is the key here. The loud breathing comes from increased airway resistance. Changes to the vagus as well happens. Yes, we get hind end weakness from that sciatic nerve. And from that, we will get muscle atrophy from that condition. But it's usually not a painful condition, except you'll have these older labs that could, of course, also have bad stifles, bad hips, LS disease on top of it. So the pain may be there, and you may just be dealing with more than one thing at a time. The key when we're looking at Gulp is the axonal degeneration seems to occur most frequently in the longest nerves of the body. And that is sciatic, recurrent laryngeal, and then the vagus. And that's why we see them in these three. We don't know exactly why yet. How do we diagnose it, right? The key here is you have to do a proper workup because other things in middle-aged to geriatric animals, of course, can challenge their ability to swallow or to breathe. So you really have to do a sedated laryngeal exam. I like to get chest films. I like to get cervical films, make sure that I'm palpating around here. They don't just have, unfortunately, right, giant lymph nodes, or they don't have a palpable thyroid tumor that could be pressing on their larynx. And then a sedated laryngeal exam, right? And we can prehab these, as we're going to talk about. And then, unfortunately, as far as the LARPAR aspect of this goes, the only true intervention right now, as far as a salvage to improve it, is a surgical tieback, which we'll get into a little bit later. The risk, of course, with that is aspiration pneumonia. We're permanently going to open up this airway. Right, here's our normal larynx on the left. And remember, so what's happening is these arytenoid cartilages, one on either side, are innervated by the recurrent laryngeal nerve, the muscles that control them, right? So if it's not being pulled back, then you have a very narrow airway. And you can either have unilateral collapse in, or you can have bilateral collapse in. And what I want you to think about as an analogy for this is take an empty paper towel tube, hold it up to your mouth, and breathe through your mouth. Super easy to breathe through. Great, you can do that. You can walk down the street doing that. If you were to take a drinking straw and hold that to your lips and only breathe through that, right? How hard is that to breathe, especially walking down the street in the heat, okay? So what happens is when you get that collapse of that arytenoid cartilage, you then get turbulent air. There's just not enough movement. There's not a wide enough area for that to go through. And that creates turbulence and edema and swelling in most of the soft tissues around the larynx, including the soft palate. So that's where all of a sudden you have no airway for these poor dogs to breathe. And I say dogs, and 99% of this, we're going to focus on dogs. Unfortunately, I don't know if it's made the literature yet, there is a case series that this has happened in cats. So it is not degenerative in cats. Unfortunately, it's iatrogenic. It's been induced at the time of intubation in cats. So if you don't have a delicate intubation with these cats and you're slamming into that arytenoid cartilage repeatedly, you can actually induce laryngeal paralysis in cats. It's unfortunate. We do our best to have good inductions, and this is why being keen at that airway and having your lidocaine to relax those that to nerve block that area can really be helpful. So again, do no harm, but also just know how these can affect and be present in your patients. As we take a closer look at the dogs, just to strip away what we're dealing with, just a friendly reminder about functional anatomy, right? Soft palate back here. Moving further back, we have our palatine tonsils, and then our epiglottis, our thyroid cartilage, and moving into our larynx. And then running, of course, slightly parallel to that is our esophagus. Looking head on down the dog, right? Arytenoid cartilages to either side, and then vocal cords just inside of that. So that's where that bark change can come from, right? If they don't have enough control in that movement area of those muscles and structures, then the voice is going to change. Here's another way to look at that, right? We have the tongue in the way here, right? We're focusing just past the tongue, just at the level of the epiglottis. Sorry about that. Just at the level of the epiglottis, moving to the top of the larynx. Another way to look at this as well, right, is just what are we trying to see in here? What could collapse, right? And if we think about this in a Labrador or German Shepherd, there's a fair amount of space. But we've also seen laryngeal paralysis in our brachycephalids, and there's no airway for that poor dog to begin with. So this is where this can become a very prevalent problem. This is a video, I'll loop it a couple of times. This is me doing a laryngeal exam on a dog who had come in as a rehab patient, but we wound up working it up. So I want you guys to see what's happening here, right? And this is the short video I have looped. I did not like this dog go on and on. We immediately intubated this dog because he came in crisis, but you can see that there is no movement, right? You have flutter of the arytenoid cartilages in the larynx. There's no viable airway for that dog to breathe through. So it starts with laryngeal nerve dysfunction. We then get damages, we get decreased cartilage abduction, we get that narrowing of the airway entrance, and then we get resistance. From resistance, we then get increased airflow, velocity, and turbulence. We get that edema of those soft tissues. And this now becomes much like arthritis. This can now become a vicious cycle of what's going on in that dog's airway day in, day out. So the moment it goes outside, it doesn't feel that humid to us, but it can be really challenging to them. And I do see some questions popping up in the Q&A. It's a great place to put them. I will get to them all as we finish up at the end. So this is a video. Let's see, this played in pre. Let me see if I can get it to play in the browser. And I'm not going to be able to do that. Shoot. So this is a video. I apologize for that. This is an older chocolate lab that was just having increased respiratory noise just walking in for rehab. This is not the dog in the last video, but one very, very similar. So that's the LARPAR aspect of Gulp. Let's move in to the polyneuropathy side, right? The vagus nerve, again, is one of the major nerves of the body. Vagus is Latin for wanderer, and this nerve wanders throughout the body, right? And so this can also lead to some of the newest research out of MSU, right? This can now lead to poor swallowing function, right? So it's not just getting the food in the away from the larynx and down into the esophagus, but now potentially with poor innervation of the vagus, you can then lead to swallowing dysfunction, muscle atrophy in that area, and then also with a polyneuropathy, you can affect the sciatic nerve, which could hind limb weakness. So those clinical signs are going to be a lot, right? It's that airway noise, noise when panting, the increased respiratory stress during excitement or hot or humid weather, lagging behind at the back of the leash, doesn't want to go out on walks, gagging, right? The ability to try to take a treat, especially something dry that kind of gets stuck in that edematous airway, or sorry, in that edematous laryngeal area, and then they're gagging on it. So you start to have a picture in your mind of what these older dogs look like that are really having a very hard time. What are the long-term expectations? As far as we understand it, it's a slow, progressive degeneration of the nerves. It can affect one nerve, as in just the left recurrent laryngeal, or it could affect the recurrent laryngeal on both sides and the vagus and the sciatic. So it's a challenging area with that. What we don't do with this, because it's commonplace and we've diagnosed everything else, or we've done a diagnosis of exclusion and ruled out neoplasia and things. It's not overly common for us to do nerve biopsies for this. It's a fairly common and understood disease at this point, but you always could if you needed to, but it's not going to change really how we're going to treat these. Over time, that the generalized hindlimb weakness and muscle atrophy is going to occur. The dog's going to have a harder time standing up. If it's not walking as well, it's not digesting as well, right? Things can really start to build up on here. And our job in the rehab field is to support the patient, to support the clinical symptoms and treat symptomatically. From a surgical perspective, what can our colleagues do, right? If we have a normal larynx here on the left, let's say we have bilateral paralysis. This dog comes in respiratory distress. It gets anti-anxiety meds. It may even be induced to general anesthesia and intubated. And we've confirmed that there is no mass at the top of the larynx, that there's not an obstructive neoplasm or infection or abscess. Then the surgical correction is a unilateral, oftentimes very rare cases bilateral, a unilateral arytenoid tieback. So they're going to go in and permanently tack back one of the arytenoids so that the dog can have an open airway. Now, by having an open airway, it also doesn't have a closed airway when it swallows food. So first off, we're going to get this dog through immediate post-op pain and management. They're going to be able to breathe. We're going to get them home, keep them nice and calm for a couple of weeks while everything heals. But during that feeding period, we're now going to do, usually I like meatballs made out of canned dog food. And I prefer 3 to 4 small meals a day, honestly being hand fed. I know it's obsessive compulsive, but we do it for a reason. Okay. It's a Labrador. What does Labradors like to do? Wolf down food, right? You feed them a bunch of dry food, it gets a piece of kibble or more lodged in its trachea, and now it can't breathe. Okay. Small meals, easy to digest, already full of moisture. Canned food is really helpful here. So how else can we support and care for that geriatric onset of laryngeal paralysis and polyneuropathy in these patients? Well, the surgical intervention, absolutely. Stay smart, stay cool, right? If it's 100 degrees out, instead of a 20-minute walk that goes a mile, go a quarter of a mile, or don't walk that day. That's all right. Let that dog out to urinate and defecate, and I'll have them walk in the house, right? Walk in the basement, walk for 10 minutes around the dining room table in the AC, right? Keep that patient out of harm's way. Be careful with exercise and activities like we talked about, right? Just be smart on this one, right? Walk at the beginning of the day or walk when it's cool out. Get these patients in for proper physical rehab, right? Targeted exercises to build up on muscle and core strength. A lot of these dogs, unfortunately, are also obese. That doesn't help them, right? So you can take this generalized patient and go, okay, we can knock some things down here and help this patient to have less stress. There are some patients that we only see during the hot and humid months. Perfect. But if your environment is like Phoenix, Arizona, even though it's not humid, it's pretty hot. And it can be hot all year round. So you may be seeing these patients on a maintenance schedule to keep them in decent shape. If they have had a tieback, right, it is sometimes helpful to raise the water and food bowls a little bit so they're just not having to throw the food back into that larynx as much as they would if the bowls were flat on the ground. But I also really, these patients are cooling vests, okay? it's an endorsement, but we're not sponsored by them, but Roughwear makes a really nice one. Okay. You want to get these dogs cool. You want to keep them cool, right? They can be really helpful to do that with if they've been out and about. So if you know you're going for a walk, maybe they put it on afterwards, get them into AC, or if you know you're walking around a little bit, it's added weight, but it can keep them cool and keep that body temperature cool. I don't want anything like a scarf or things around their neck. I don't want anything super tight there. You can also, because these dogs have polyneuropathy, usually sciatic neuropathy, right? We can use things like small scrunchies or hair ties around their feet as proprioceptive aids. We use these only on walks and only when we're doing land-based exercises, but we can use that in the rehab center. Or if we have the owners, we can do it at home. But I'll also use, if it's not bands, if they don't like that, is I'll use kinesiology tape. Okay, because I'm just trying to cue up those proprioceptors in those distal limbs so that the dog's a little bit more aware of its feet and has to pick them up a little bit more, right? Those little steps can then build the cranial tibial muscle, build up the hamstrings a little bit, right? We're just trying to slow the progression of that disease. So building up muscle is important. Core band is another proprioceptive aid. This is a TheraBand around the ventral here that may improve core muscle strength and stability. Kind of like knowing you have a belt on, right? So you can put a little bit of pressure here. You do have to be super careful. 99% of these we only do in the rehab center under our direct professional supervision. Absolutely, right? When you have a LARPAR dog or a Gulp dog, I treat this like a cervical disc dog. They don't wear a flat collar ever again, okay? I want these dogs on a harness, and I want them on not on a front no pull. I want them on something attached on their back. I want nothing anywhere near the larynx with this dog, right? This little pitty is easy, right? It's going to lean into that. It's going to pull. But if this is an older dog and it's walking ahead, right, or you're yanking up on, you're going to put a ton of pressure on that larynx. So absolutely no neck wear at all. These are some decent ones, right? We like our help them up harnesses. They're not going to put pressure there. I would even ask the photo, but I was like, why do we still have a choke chain on? Clearly has LARPAR and issues, so I would take that off. Again, we want things that don't impede shoulder movement either, so these are helpful ones to have. And then how do we phase in the role of an assisi loop into Gulp, right? Because there's not a pill here. This is strictly an exercise and lifestyle management disease. Before we get into the assisi loop with this, about 10 years ago, there was a couple of clinical trials looking at doxepin for the role of potentially decreasing the severity or slowing down the degeneration with laryngeal paralysis. DOXEPIN hydrochloride. It's actually was used in derm as an anti-itch drug. Long story short, we're not using doxepin all the time because it didn't pan out in the clinical trials. So there's not a pill, right? Can we use maybe a laser on this? Sure, but that's really in the clinic, right? There's no proven benefit on those either for this. Concept-wise, maybe sure for edema, but a hard area to really treat through all the thickness of the outside skin. And so we really look at this and go, can we use, what else do we have in our toolbox? What else do we have at home? And so let's look at pulse electromagnetic field for these. Just as a friendly reminder, PEMF, right? Targeted pulse electromagnetic fields are electromagnetic pulses that enhance nitric oxide signaling that the body uses to combat inflammation. So it targets 100% of the signaling pathway to then enhance that nitric oxide. That leads to an increase in blood flow and a reduction in pain and inflammation. Where does that research come from, right? Because here's the organic chemistry part of it, right? It's alternating, it's modulating calcium calmodulin, which Kirsty does a much better job explaining than I do. So I'm going to skip this and we're going to talk about some of the research here. Pulsed electromagnetic fields in the 1970s were about the size of a small car, and you had to be hooked up to them for 12 hours a day. And they were used to help stimulate bone healing in delayed unions. As the technology got better and smaller, they became more portable. And where they were then studied as a loop was for women going through breast cancer surgery, right? And so they were used in those areas, and those in double-blind placebo-controlled studies, the patients on the targeted pulsed electromagnetic field had less scarring, needed less pain meds, and had better flexibility of their torso post-op. Okay? You can pull those papers, right? Then in vet med, we looked at it specifically in dogs. One study it up at AMC, another study down at NC State, double-blind placebo-controlled studies of dogs going through hemilaminectomies, right? So dogs that needed a hemi, they all got their hemis. Half the dogs had a placebo loop, half the dogs had a treatment group, and both in hospital and at home, the treatment group needed less injectable pain meds and less oral pain meds at home. And in both studies, the dogs that were in the treatment group with the loop had a faster return to normal neurological testing. Not that the dogs without it didn't get there, but the dogs with the loop got there faster and more efficiently. So that's the device. That's where we're using it the most, right? But we can start to use those things in our rehab potential space for other patients. When we have that loop, to come back to this image, right? The battery's here in this little brooch. The wire is wrapped by this rubber by the rubber, and that puts out a wave of electromagnetic field in each direction. And depending on the size of the loop, it's going to put it out for a different diameter, of course, and for a slightly different distance in either direction. We'll stay with the cell wall stuff, right? What I really appreciate when Kirsty and I both started speaking for Zomedica was looking at the research ahead of time. And with all of these different devices, different electromagnetic fields with different wavelengths and pulses are used. So one EM device is not equivalent to another, okay? You have to look at the research for each individual company's PEMF device. And with the CC loop, they know that they have the benefits to target those cells and tissues. Specifically, they have all the research on the cellular level, on interleukin-1 beta, on calcium, on nitric oxide, and calmodulin. So we'll skip over the cell wall stuff and get into the nitty-gritty, right? Well, let's go back to what we know about Gulp, right? We know we have edema of the soft tissue here, okay? So how can we reduce that, right? Can we spray lidocaine spray down the dog twice a day? Okay, is it really practical? Is there any studies showing that if we put the dog on carprofen or any other NSAID or on oral prednisone, are we going to decrease the edema, right? No, there isn't any study on that, right? So how can we get an anti-inflammatory aid to an inflamed condition? You can take that a CC loop and put it over the dog's head, okay? Here's this old lab, right? This is the one we played before, unfortunately, right? But here's one that this is the owner can do this at home, okay? So they take off all their other collars. We don't want any metal implants in the way. We don't want anything like a pacemaker, right? So if this dog had a pacemaker, pacemakers have to be 12 inches away from the CC loop. Otherwise, you can interfere with the pacemaker. Same pace that applies to the dog and the owner, okay? But here, for this dog, right, they can come in, we take off their collar, pop in a CC loop over their head, turn it on. It's going to be a 15-minute treatment. So we can use that while that dog is exerting itself through its 15 minutes of therapeutic exercise in the rehab center. We can then have that owner do that a CC loop at home, right? 3 times a day, especially on treatment days when they come for therapy. We also like to have them treated for the 15 minutes ahead. So if they can, if they're on their way an hour or two ahead of time, or that morning they know they have rehab, or before you go for a walk, or after a walk if it's humid, here's a way to target inflammation without putting any stress systemically on the patient. Bulldogs, pugs, and Frenchies, same exact rules apply. Okay. All these dogs can get this. We can absolutely take these dogs, even if they don't have laryngeal paralysis, this time of year, these poor brachycephalic patients also have an absolute ton of edema. They have a hard time cooling, so they can also benefit from cooling vests and from a CC loops to decrease the inflammation in their airways. So, in summary, right? Gulp usually affects larger, older breed dogs. The frequent early signs absolutely is that change in bark, and that obstructive airway disease is going to be the progression. Right? It gets narrower and narrower. It is harder and harder for that dog to breathe and exert itself. You can absolutely see hind limb weakness and muscle atrophy. That's going to lead to exercise intolerance and a loss of quality of life. So we talked about using the CC loop over their neck really for the LARPAR. You absolutely could put both one or both legs through it and treat the sciatic nerve as well. Now that's an axonal degeneration, so we have less inflammation in that area, but there's probably some muscle inflammation in there as their dogs are using those muscles differently. But if I'm going to pick a spot when I'm dealing with this disease, I really want to get rid of that soft palate and laryngeal edema to help improve that airway for those dogs. What else do we have to do with these, right? This is a critical client education, right? We have a handout on these. We sit down and talk with them about it. We want them to go to reputable websites, and Michigan State has a very, very reputable website on this disease. We talk about lifestyle modifications and exercise modifications. We go, hey, how can we help here, right? We want them to come in and do stuff, yes. If they need a tieback, yes. And honestly, when I've diagnosed LARPAR, if I've diagnosed it and done my laryngeal exam as a veterinarian and make sure I don't have anything else, right? Because I don't want to ignore this. I don't want to assume it's LARPAR because it also could be a tumor, right? It could be something that we could intervene early and have a better outcome for, right? So we want to be a good diagnostician and do that laryngeal exam. When I do that, I don't immediately say, well, your dog absolutely needs surgery. What I really want to emphasize with these owners is I really want you to go and get a surgical consult. I want you to talk with the surgeons about the pros and cons of a tieback so you can have that in a calm environment and take that all in. Because when your dog comes in at 3:30 or 5 o'clock in the afternoon, right, coming in through the ER when it's cyanotic, when its airway is completely shut down, and when it's so edematous that we can't intubate it and we have to do a temporary trach, you're not going to be thinking clearly as a pet parent, right? So have the conversations about surgery so they're informed and they're educated. And you're going, Brunke's overdoing it. How many dogs need a temporary trach? Yeah, we had two that needed, one that needed intubation and one that needed a temporary trach just last week. Okay? It is hot. It is nasty out. Be good advocates for your patients and set them up for success. You diagnose this, have them talk to surgery. Let them know what they're in for. Let them understand what the costs are going to be, right? But be a good diagnostician. And then once you've made that diagnosis, to me, an CC loop is a fundamental treatment for all of LARPA, right? It's something easy for the owners to do at home. A loop has 150 treatments. It's going to last about 6 weeks. Gee, maybe that's something that we do just on those 6 weeks of summer, right? When the heat and humidity are really bad. Because I don't want my own dog to come in laryngeal distress and laryngeal shutdown. We don't want that for any of our patients. What other online resources? This is all about Gulp, which is an awesome website. Right? Are there other things to do for Gulp? Absolutely. Just outside the scope of here, things, acupuncture can be helpful. Can they come in? Sure. But we don't have a great pill for this. And we have a salvage surgery. So why do we not do an intervention that has easy to do at home? They don't have to come in often. They can continue to be active with their dog. And yeah, I want to get this. Kirsty and I need to work on a case series and get this published because the reason we talk about this is we've had over a dozen of these patients do really well with this intervention, where we send them home with as a standard of care with an CC loop.